Dr. Brightlin will be presenting a CNS case. It is not that she will only present. So in the middle, there will be interaction with other postgraduates also, where we will be asking questions to you. Okay. And so I encourage everybody to participate in this discussion. This is a learning exercise.
Good morning, everyone. I'll be starting with the case scenario. Mr. Banking Montal, the 63-year-old gentleman from West Bengal, is a farmer by profession, presented with complaints of imbalance while walking for 1 year, speech abnormality for 8 months, and lower urinary tract symptoms for 4 months. History of presenting illness. Mr. Banking Montal was apparently normal before 1 year, and then while he was going to his farm in his cycle, he fell down from the cycle. And then he stood by himself on his own, and then he noticed that while walking, he has a mild swaying to the left side, but it actually became normal after that. So over 1 week to 1 month of time, he noticed that his swaying became progressively worsened, and he noticed that he was having this swaying which is progressively worsening, and over 1 year course of time.
So what do you describe as imbalances? Because imbalance means many things, no? So what do you guys understand as imbalance? What does imbalance mean to you? So what was he doing? He was doing a simple motor activity or a complex motor activity when he was slightly more complex because he had to balance on a bicycle. So initially his disease was that he could actually drive a cycle. Then afterwards it progressed. And so she's saying there is imbalance. So imbalance means which system in the CNS is involved. So you when the term imbalance comes, you should remember it is a cerebellum she's talking about. Okay.
So 1 year course of time, initially he noticed that he was swaying to the left side. After that 1 to 3 months of time, he noticed that he was also swaying to the right side. And during course of time, he was finding it difficult to walk through the narrow pathway. And for the past 3 months, he required support to walk as well.
So based on that progression, what parts of the cerebellum are involved? So initially he was swaying to one side. Which side?
Left side.
Left side. So which cerebellum is involved? Which part of the cerebellum is involved? So the left cerebellar hemisphere is involved. Then he started swaying on
right side also.
Right side also. So now bilateral cerebellar involvement is there. Then afterwards, what happened?
Then after that, he was finding it difficult to navigate the narrow pathway. So truncal gait disequilibrium.
So there are gait abnormalities have also started. Okay. So then you have the flocculonodular node and all also getting involved. So you can see the entire part of the cerebellum is progressively getting involved in this patient.
So for the past 2 months, he also noticed that while he was trying to sign in his paper, he noticed that his handwriting was not legible and he was not able to write normally as before.
So what are the handwriting abnormalities you know of?
Micrographia and macrographia. Micrographia will be present in Parkinson's disease. There will be progressive, smaller. The cerebellar, they will have this incoordination because of the handwriting become illegible and it will become larger in size and the words will not be very clear. Letters will not be very clear. Though he had this shakiness of hand, he did not have any spillage of food while eating or there was no smearing of face present. So,
did he have any tremors? Because
he said shakiness of hands, ma'am, but he noticed only when he was trying to sign, but after that it was persistently present, but he did not have any shakiness while holding tumbler. He did not have any smearing of face while eating. It was so he mentioned it as non-progressive. He noticed mainly during this writing is what he said.
Writing is what he said. Okay. So what are the types of tremors? Can you tell me what are the types of tremors you know of? Resting tremor. Seen in which disease? Parkinson's. Intentional tremor or kinetic tremors they are called. They are seen in what disease? Cerebellum, which is what she's trying to describe. You, what are the tremor you know of? You only resting and intentional. Any other tremor you know of? No. Any other tremors? Essential tremor. Essential tremor is actually not a classification of tremor. I just wanted to highlight that. So they are called postural tremors or action tremors. So what is the difference between postural and action tremors? Yeah, so when you actually have to hold a posture against gravity, like extend your hand and the tremor becomes worse, it is postural tremor. And when you're doing an action, it becomes worse, it's called action tremor. And both together are under essential tremor. So essential tremor is both an action tremor and a postural tremor. Okay, while like you're saying, the kinetic tremor and the intentional tremor, the action, they are all due to when you're actually moving your hand to a particular part and trying to point to get the tremor. That is a cerebellar tremor. Okay, so you should ask what type of tremor he has got.
Then 1 month later, he noticed that he had a difficulty in using his left lower limb, that he felt that it was stiff, and difficulty in lifting his left lower limb from the ground. However, he was able to hold the footwear tightly and there was no slippage of footwear. He did not trip over small objects or anything. He did not have any buckling of knees. He did not note any obvious thinning of legs. Was able to get up from squatting position and able to climb upstairs initially, but for the past 3 months, he is requiring support due to imbalance while walking.
So by that, what do you want to convey? You want to convey the weakness progressed from? Was it distal to proximal or proximal to distal? What do you want to?
I was not able to differentiate.
You're not able to differentiate.
Per se, because distal he was able to hold tightly. He did not trip. Proximal also he was able to tell that he was able to do squatting.
Okay.
He just said that he had feeling the stiffness and he was not able to lift it off.
Okay.
Felt very stiff is what he said.
What is saying? So you say okay. So you're saying the weakness doesn't follow any particular pattern. If it is distal to proximal, what do you think? The weakness is more distal rather than proximal. Which system in CNS is involved? It's usually the U1, which is distal weakness, will be more. And if it is proximal more, then you have the muscle, the muscle myoneural junctions, all that you should consider.
So initially, he noticed that only his left lower limb was stiff and had difficulty. And after 2 to 3 months' time, he also noticed that he had difficulty in raising his right lower limb as well. While upper limb, he did not mention any complaint specifically. He was able to mix the food normally. He was able to button and unbutton his shirt. He was able to hold the tight, he hold object in his hand and did not have any slippage of pen or any tumbler. He was able to comb his hair and he was able to take objects from over his head. He did not have any twitching or cramps as well. No?
So predominantly lower limb involvement.
Then 3 months later, his relative noticed that his speech has become slow initially. And after 1 to 2 months of time, they noticed that whatever words he said, it was incomprehensible and it was not legible as per the relative. But the patient did not have anything, tell anything specifically. However, he was able to understand what the relatives were telling, was able to reply, but the words were incomprehensible. Was able to repeat what was told to him, was able to read and write what was told to him.
So what do you think? It is an aphasia or a dysarthria? What are you trying to?
Dysarthria.
You're saying it's a dysarthria. Okay.
Relatives also notice that his voice tone has changed for the past 6 months. It feels as if he's speaking through his nose.
So what is that called? Change of. So he's speaking through the nose, sir.
That's what the relative.
But initially you said the voice
is slow and then ineligible.
Okay.
The relatives are not able to understand what he was speaking.
So if somebody is speaking to the tone, which muscle is paralyzed? Sir? So the palatal muscle is paralyzed. So where is the involvement? No? Yeah, 9 and 10. Usually at the level of bulbar.
Yeah, bulbar. He also said that for the past 4-3 months he has cough while eating. They are not able to tell whether it's a they tell it's nasal regurgitation was not there, but choking they were not. He was not able to tell whether he was able to. He was able to chew the food and he was able to make a bolus in his mouth. But while eating, he said there was a swallowing. There was a cough.
Bless you. So which muscle is involved more? Is there any pharyngeal muscle involvement or there's only palatal muscle involvement here? So I think there's only a palatal muscle involvement because he's not choking and he's able to swallow his food.
Then family also noticed that he had a hard of hearing. The patient was not able to tell in the last 3 months, but whenever the relatives were trying to call him, was not responding initially. Only then they noticed that he had a hard of hearing. However, he did not have any ear pain, discharge, no fever per se, no tinnitus or no giddiness complaints presently. Cranial nerve history, he did not have any loss of smell, no visual disturbances, no drooping of eyelid. He did not have any double vision. He was able to feel the sensation over the face. He was able to chew. He was able to close eyes tightly and there was no deviation of angle of mouth. He was able to taste the food and he was able to turn head from side to side and he was able to protrude the tongue as well. Now for the past 3 months, he also complained that he has an increased frequency of urination along with the increased urgency. He was able to feel the bladder fullness. He did not have any difficulty in initiation of urination. He did not have any dribbling of urine or poor flow of urine. Did not have any incomplete voiding or retention of urine. He did not have any bowel incontinence or altered bowel habits. He did not have any postural giddiness or profuse sweating.
Okay. So, Abhay, what is the order of neurological system examination which he has presented? And how do you usually present in neuro? What is the order of presentation?
You start with history and then go on to tell the cranial nerve.
Before cranial nerve, I
Higher
thought
mental function,
higher mental functions.
then the cranial nerve,
Hmm.
then the motor system examination,
Ah,
then the birth, tone,
ah.
power, reflexes, superficial, and deep.
No, sensory and then only reflexes. And then after that, yeah, gait, stance, cerebellum, and autonomic and meningeal sense. So that is the way you will present the neurological history also and do the examination. Okay, you have to systematically follow it, which Dr. Brightlin has followed and demonstrated to you by this case presentation. Yeah.
Then summarizing.
Other system review.
He did not have any loss of weight or loss of appetite. He did not have any cough or breathlessness. He did not have any bone pain. Did not have any rash, oral ulcer, or joint pain or anything of that complement. Past history, there was no previous similar illness in the family, no previous history of vaccination or dog bite. Treatment history, he was not treated elsewhere for this.
Okay.
He did not have any intake of alternative
No, so
medication.
we have to ask relevant history for him. So we see that what do you think this disease is? Now with the age, Abhisha, what do you think the disease is? It's a congenital disease, genetic disease, degenerative disease. What kind of disease would have affected this man at the age of 63? It's a degenerative disease. So we have to basically ask for family history, whether not of dog bite and all that. So like whether there is similar illnesses in the family, whether any other dementias is got. Well, he has also lost voice. So we have to ask for history of a disease called primary progressive aphasia, which is a kind of a dementia where they stop speaking. So, and one thing I wanted to highlight here is that what are the functions aphasia? If somebody has aphasia, Hamsa, what are the functions which are lost? That entire language is lost. So in other than listening and speaking, what are the other ways the language is lost? Writing. So she said, no, writing language also will be lost. So we should always remember that. Okay. So that she demonstrated. So we have to ask history of any other illness, degenerative illness in the family. So any other degenerative illness in the family?
They said that there were no other family members affected with any neurological no dementia features.
Please make it a habit to draw the family tree for all your neurological patients. So family tree has to be drawn. Okay, so are the affected and him, what in any other issues, we have to draw the family tree. Because there are a lot of diseases which he is older, but if he's a 40-year-old man and has a similar kind of a degenerative disease, what are the other metabolic diseases you can think of? Yeah, Wilson's is very common in India. So you have to draw the family tree and find out, especially in degenerative neurological diseases. Okay, so family history is a must. Anyway, you said that, but I'm just saying. Rabies, do you think this person has rabies? Jagasit, do you think this patient could have rabies? Could he have dumb rabies because he stopped speaking? No, because it has been going on for a long time. Rabies is a very, once it involves the brain, it's a very acute disease. People will, within a month, usually, their lifespan will be a month after diagnosis of clinical rabies. In dumb rabies also, they stop speaking, by the way. So they will be quiet, they will not be aggressive. But still, this is a chronic, progressive, slowly progressive degenerative disease. So please do not ask for history of dog bite and all that. Okay, that is what I want to say. This is not rabies. Rabies has what part of the brain is involved? It is brainstem. So there will be involvement of brainstem. Okay. Here, cortical functions are lost. Okay.
Personal history. For the past 2 to 3 years, he has sleep disturbances. Whenever he dreams, he wakes up in between the sleep and screams or talk about his dream. That is present.
So, John, what part of the sleep cycle is disturbed in this person? REM sleep. So, in which disease rapid eye movement sleep is affected? Which degenerative disease? Parkinson's disease. So now we know that we are moving in a degenerative disease towards Parkinson's. Some REM sleep abnormalities are there.
Summarizing.
Okay.
63-year-old gentleman presented with insidious onset, gradually progressive, imbalance while walking, swaying to the bilateral side, slow speech with nasal twang, decreased hearing, stiffness of all four limbs, and bladder complaints. Localized.
Okay. Which CNS systems are involved? Anybody with CNS systems are involved in this person? What are the systems within CNS which are involved? Cerebellum. Because of imbalance. Namrata, what are the systems are involved? Okay, Prenal's 9 and 10 probably. Then Kezia? Okay, motor system. So which can be either pyramidal or extrapyramidal. We don't know for now, but for the stiffness then. So anything else start? 8, 9, 10, cerebellum and pyramidal. Oh, okay, we'll see.
Coming to the examination, general examination was moderately built and nourished. He had a mask-like facies. He did not have any external features of malignancy or tuberculosis. Vitals, his BP at the time of presentation in supine position, it was 130-80 millimeter of mercury. While standing on 1 minute, it dropped to 160 millimeter of mercury. So he's got a postural hypotension. So along with the bladder complaints, if I feel that bladder complaint could be related to BPH, but now he has a postural hypotension, I will attribute it to the autonomic dysfunction. Then higher mental function, he is right-handed, conscious, oriented to time, place, and person. His memory 3-word recall was normal. His recent and remote memory was normal. Speech, he had a scanning.
So, we were discussing in the last clinic. How do you say 3-word recall is for what memory? Immediate memory. So how will you test for recent memory?
What you have eaten yesterday.
No. So that is what. So I want to clarify that. So as from because of another recall is so immediate memory is immediately showing 3 things and asking them to repeat. Recent is after 15 minutes. Ask them what did I show you? What are the 3 objects I showed you previously? And then remote memory is like you ask them important events in their life. But the recent memory is checking the 3 objects again. Okay, after 15 minutes, don't ask for what they ate. That is not considered recent memory.
Then speech, he had a scanning speech with nasal twang. Comprehension was normal. Repetition was normal. Fluency was fluent. He did not have any hallucination or delusions.
If they have hallucinations, what disease you will consider? Vivekanandan, what if you have a degenerative disease and they are having hallucinations, then what disease you're thinking? It's some body dementia, it is called. Lewy body dementia. So when they have hallucinations, you will consider Lewy body dementia. So that is what she's ruling out here. So this also should come in your earlier history that you're ruling out Lewy body dementia.
Cranial nerve examination. Optic nerve visual acuity was bilaterally 6/12. Visual field was full range. Color vision was normal. Fundus was normal. 3, 4, 6 extraocular movement was normal. Direct and indirect right reflex was present. There was no ptosis. Accommodation reflex was present. However, he had a horizontal nystagmus present on look, which was gaze FO. Fast component towards the side of the looking. He also had a slow saccades as well as broken pursuits.
How do you check for saccades? Teacher or first years?
So,
and which disease saccades are broken?
Cerebellar.
No, Parkinson's. Saccades will become slow in Parkinson's. So tell how you will teach your first years how will check for saccades.
So in front of the patient in the eye field level, I'll be sitting and within the field range, I will keep either the 2 objects. Either it could be my finger. I'll ask the patient to look at each finger alternatively when I tell. So the patient should have a slow saccade he should be having this smooth flow of the eye movement. If it is lagging behind, then the patient is having the slow saccades.
So you keep your hands in the field. Don't keep it like this. And then say right, left, right, left. So they have to move their eyes quickly across the sides. So saccades will get broken if you have Parkinson's.
Pursuits also, he is not able to. So fast tracking of the movement, you should be able to track. For him, it's not present. Then trigeminal nerve examination, sensation was present bilaterally. He was able to.
So tell us the trigeminal nerve. branches because you brought in trigeminal nerve. Which part V1 is which, V2 is which, V3
V1
is
is ophthalmic.
ophthalmic, and up to how will you test? Till which part of the
Conjunctival kernel and the tip.
till the tip of the nose you should test. So this is the V1. Then
maxillary and mandibular.
so maxillary
above the angle.
So angle of the mouth. Then
below that mandibular.
Mandibular. What is the angle of the jaw?
Greater auricular.
Yeah, what it is, which is supplied by the
greater auricular.
Correct. It is not. You should not touch here and say I checked for fifth nerve. Okay.
Jajak was not exaggerated. Facial nerve examination. Wrinkling of forehead was present. He was able to close the eye against resistance. There was no deviation of angle of mouth. He was able to blow the cheeks and hold air inside the mouth. Taste sensation anterior to that he was able to perceive. Then eighth now, Rinne's test bilaterally it's bone conduction more than the air conduction. Weber's for him it's laterally to the left side, but it does not localize whether it's with the Weber alone. I cannot tell, but with the Rinne's test, I can say that patient is having right-sided sensory neural hearing loss.
Okay.
Glossopharyngeal nerve, vagus, glossopharyngeal and vagus. Uvula is midline, but however it looks atrophied to me. Then palatal reflex and pharyngeal reflexes lost me. He was not able. There was no movement when I touched the posterior pharyngeal wall as well as the palate. Spinal accessory now. He was able to shrug the shoulder. He was able to turn the head side to side. Hypoglossal nerve. There was no deviation of angle of mouth. No fasciculation. It was tone is also normal. There is not spastic or flaccid. Most motor system.
Tone of the tongue. You're saying. No, what did you say? Tone
for
the
this tongue. Motor system examination, no muscle wasting noted. Bulk was bilaterally right and left side. It was almost equal in the mid-arm, forearm, thigh, and leg. Tone.
This is a point I want to like. So these the purpose of this presentation is to standardize your presentation across all the years. So bulk has to be measured in from bony prominences. So from the olecranon in the upper limb.
In the tibial tuberosity.
Tibial tuberosity or the patella in the lower limb. Okay. So it's 10 centimeters up and down in the hand and the arm, and in the leg it is 18 centimeters up and 10 down. So you should always measure bulk and mention it, simply because you will miss certain diseases where the bulk is very clearly like they're lost in the shin or things like that. For example, like a charcoal mari tooth. What is the appearance, Namrata, in that called? Yeah, inverted champagne bottle appearance. So there is a stark, like a abrupt cut off. The bulk will be less in the shin and the leg. So for it, you have to measure bulk and mention it in centimeters. Please remember that for your exams. Okay.
Then tone, ma'am. Upper limb it is bilaterally spastic, and in the lower limb also it's spastic, ma'am. In upper limb it's extension is difficult than the flexion. In the lower limb, flexion is difficult than the extension.
Okay, so now we are introducing a contradicting concept because now we are all moving towards extrapyramidal. Now she's saying pyramidal is also involved because spasticity means there is pyramidal involvement. So, and usually it will be seen over which movement. So when the tone is involved, when there is spastic tone, which muscle is involved? Flexors. So she is now saying a new concept, saying it is more over the extensors. So please remember the spasticity, the tone will be more over the extensors, flexors and upper. Okay. So you should remember that. Okay. And so, and then and there is no lead. Is there a lead pipe rigidity? Okay. Any other types of tone you guys know? One is the spasticity she mentioned. Then there is lead pipe. Then what is the other rigidity? Cogwheel rigidity. And then what is the fourth type of tone? Have you heard of? Paratonia. Number that's correct. So this is paratonia. So in people with degenerative nerve diseases, you ask them to flex or extend, what they'll do is initially there will be severe resistance. You will think they are actually pulling their hand back when you're trying to test the tone. That is called paratonia. See in degenerative disease. So are you sure this is paratonia or do you think it is still spasticity? I'm just asking. Paratonia means there is frontal lobe involvement. Please remember that. So you might not have frontal lobe. Till now we have not got any clinical clue for frontal lobe involvement in this person. Okay. So you want to stick to spasticity. Okay, we'll see. So again, I want to make the point that when you're checking for spasticity, because we discussed it in the plexus. So spasticity, when you're checking tone in UMN, you should check over the biceps. You should not check over the triceps and say that is I'm checking tone for a UMN. So you should check for the biceps and the pronators in our hand. Okay. Power can be 5 by 5, and she's asking, is there still spasticity?
So against resistant, when I checked, I could feel that he was able to do it against 5.
5 by 5. We don't know. She's presenting. We have we'll examine him and we will see the power. So as of now, as our presentation, there's spasticity and there is power. But human lesions, the power will be maintained to some extent till the end. Only element the weakness is here. So we are thinking that it is around 4 plus or 5. We will see how she proceeds.
So power in neck flexion extension he was able to do. Shoulder flexion, extension, abduction and adduction he was able to do. Power is 5 by 5. Elbow flexion, extension, supination, pronation also is 5 by 5. Wrist flexion and extension, abduction, adduction is 5 by 5. Hand grip was good, ma'am. There was no obvious wasting of this small muscles of the hand. In the lower limb, hip flexion and extension, abduction and adduction was 5 by 5. Knee flexion extension also 5 by 5. Ankle dorsiflexion, plantar flexion is 5 by 5. Reflexes, superficial reflexes, sensor system.
She's again sticking to a UMN way of presentation. Please remember, when you have a stroke case and you have a UMN way of presentation, you will present at the movements, because upper motor neuron affects movements. So if you for a stroke patient, what are the muscles which are affected? The Shakti. If there is a UMN like a stroke patient, which are the muscles which are maximally affected? In the upper, what are the muscles? The extensors and the so the abductors and in the arm, the abductors and the extensors are affected. So for when you are talking about a UMN lesion, you have to mention power at movements. So that is what she is demonstrating. So please remember, at joints, the power has to be mentioned at movements. But if you have an element lesion, you're thinking of peripheral neuropathy, then in the same way, instead of saying that the flexion and extension of the hips, the gluteus maximus power is this much, the iliopsoas power is this much. To say, you have to examine individual muscles. Though you are examining the same movements, for element lesion, it should be mentioned at the muscles. Okay. So remember that when you're doing your presentation for your exams.
Sensory system, touch, pain and temperature was present bilaterally normally. Vibration and positions and also was normal. Cortical sensation, tactile localization, stereognosis, graphesthesia and 2-point discrimination was able to perceive normally. Coming to the reflexes, superficial reflexes, corneal and conjunctival reflexes was present bilaterally. Pharyngeal and palatal reflex was absent bilaterally. Deep tendon reflexes, jaw jerk was not exaggerated. Biceps was 3 plus brisk in bilateral.
Biceps is brisk, huh?
Triceps also is 3 plus bilaterally. Supinator also 3 plus. Knee is 3 plus. Ankle is 2 plus. There is ill sustained ankle clonus in the that patellar clonus bilaterally.
Patellar clonus is also there.
Ill sustained. Then plantar bilaterally extensor.
Extensor.
So cerebellum. Initially, I mentioned scan speech and nystagmus. I have mentioned that I'll include here. Other thing is finger nose test is impaired bilaterally. However, it's
why did you report nystagmus? Please remember, nystagmus, though Bickerstaff puts it in 346, should be reported only under cerebellum. Please mention it only under cerebellum when you're presenting. Do not present nystagmus under 346. But if you see the order of Bickerstaff puts it in, he actually puts it into 346 because it's a part of the examination of the eye. But it implies cerebellar or vestibular system involvement. So when you're presenting in your cases, please insert it into the cerebellum only.
Okay. So finger nose test and finger nose test was impaired bilaterally. It was more involved in the left more than the right. Histidega kinesia was also present bilaterally. Heel shin test he was not able to do. There was rebound phenomenon on the right side compared to the left side. Gait was ataxic gait and tandem walking he was not able to do. Romberg's on checking he was swaying to the both sides. He did not fall. there was no neck rigidity, spine and cranium was normal, and there is no peripheral nerve thickening. Other system examination, cardiovascular system examination, first outcome, second outcome was normal, and there were no murmurs. Respiratory system, bilateral air entry equal, abdomen, no organomegaly, and no fluid.
Fundus, sorry,
Fundus.
fundus normal.
Now coming to the diagnosis per se, the structures involved. So he has a 8th cranial.
You ask them now. You have presented like ask somebody. John Roy, not John Puri. What are the? Were you here for the full presentation? Were you here for the examination? Okay, tell us what are the structures which are involved. You think?
The spasticity, intensity that the pyramidal gland is involved. The broken saccades and the ataxic gait will tell me that the cerebellum is involved.
Okay.
Uh,
Ataxic gait is cerebellum. Okay.
Also, the abnormal finger nose tumor and the
Yeah. Kinesia. Okay. So the cerebellar hemispheres are involved. So through and through, entire cerebellum is involved bilaterally. That is what we understand. Then.
Yeah, 9 and 10, based on the history, the fact that we had dysarthria, we can do that 9 and 10.
9 and 10 are involved. Then. Yes, sir. What other systems are involved? Autonomic nervous system is involved. Okay. So then.
But if you consider that broken saccades to be an extrapyramidal symptom, an extrapyramidal, and that tremors also history-wise he had.
So she's saying that there is extrapyramidal involvement also because there is tremors and also there is broken saccades and also history-wise there is rigidity. What do you see?
Spasticity.
Spasticity is pyramidal.
Yeah. So only these two things.
Okay. Then that's what 9 and cranial nerves are 9 and
8,
10.
9, 10.
8, 9, 10.
Then say pan-cerebellum, pyramidal as well as extrapyramidal and autonomic nerve system.
Autonomic nervous system. So now can somebody offer me some differentials? A degenerative disease in a person more than 63 years has been progressing over how many days?
1 year.
Has been progressing over 1 year. So who would like to offer them? Yes, sir. Multiple system atrophy. Okay. You're also Hema, no? See with you. Okay, so there's multiple system atrophy. There are many systems which are involved. Right? Any other things you can think of? Okay. What about prion diseases and all? No?
But it will be progression over 1 year. It will not be there.
Yeah, prion diseases are very slowly progressing. Huh? Cranial involvement is usually not there. So what are the systems which are involved? I want to argue and talk about it. It's not that I tell and you learn. So numbers are saying cranial nerves are not involved. Which I completely agree with. So what are the systems which are involved mainly in prion diseases? They have lobar involvement. So maybe they have lobar involvement and they'll have like subcortical involvement. They actually involve mainly the brain rather than the nuclear area. They involve the cortex more than this. Okay. Any other diseases?
Involving all system
Involving all systems, you are not able to think of anything else. Any other?
Paraneoplastic.
Thanks for the patient. Okay, I'm biased.
You are biased. Okay. Then anything you want to say?
But again,
Remitting Paraneoplastic.
Paraneoplastic involvement can be there. Like an entire thing can be a paraneoplastic syndrome. So we have to offer multiple definitions. So this is involving many systems. So you have to put in at least 3, 4. So one is paraneoplastic. So you can have lymphatic involvement, cortical involvement. Paraneoplastic meningitis in one. It can also be seropositive. You should not always throw away HIV out of the picture. So it can be seropositive with like what is that disease? HHA, multifocal leukoencephalopathy and things like that.
Spinocerebellar ataxia cannot be rolled out with whatever features you're having. Except for the age of those.
Spinocerebellar ataxia also could be, because they also have deafness. So that can be spinocerebellar ataxia also.
I think there is one factor in the history that straight away makes you think of the multisystem atrophy, which I'm not sure. It's not
REM
here for
sleep.
history. So,
REM sleep disturbance.
yeah, you did present that.
Mention this one. So sleep, REM sleep disturbances are very particular. That's what Amit is trying to say. That means if REM sleep disturbance is there, it automatically enters into the Parkinsonism group of disorders. If you see those 5 things, bradykinesia, rigidity, tremors, and it actually says REM sleep disturbance. If these 5 features are there, then you should consider Parkinson's. So it becomes Parkinson's group of diseases. So that is why it's talking about REM sleep disturbances. Okay, so now we have come to a conclusion. It's a degenerative disease affecting the elderly, and it's most probably a multi-system atrophy. What type it is?
C cerebellum involved. C is more involved.
Okay, so it is MSA C, she's saying, because there is involvement of the cerebellum. Okay, what is the other type of
Parkinson's?
MSA P, which is they have predominantly Parkinson features. So that is MSA P. Okay. So then. So as a part of your long case presentation, you should also tell me what you want to do for this person.
So as for the initial evaluation, I'll send off the basic blood test PVDs and go for the MRI to look for any MRI brain with contrast to look for any.
So you want to work up only for a MSA C automatically. So go and do an MRI. Okay. Then in that case, I will have to ask you what the MRI findings.
They'll have atrophy of the Pons cerebellum having hot cross bun sign because of this.
Okay, the typical is the hot cross bun sign, like you say. Okay, so if you have a degenerative disease, automatic thing is to do a MRI. And if you, okay, any other Parkinson's plus diseases you know?
Progressive supranuclear palsy.
Progressive supranuclear palsy.
And corticobasal degeneration, Lewy body dementia.
Corticobasal degeneration is the rarest of them all.
Lewy body dementia. Drug.
Okay, so when you're asking history, you should ask for history of all these also. So Lewy body dementia, I mentioned saying there's no hallucination. And corticobasal degeneration, what are the features they'll have? You should do, huh? If it is a younger patient with Parkinson's, what metabolic disease will you do? We already discussed.
Wilson's.
So in your general examination, when you say neurocutaneous markers also, if it's a younger person, please say there is no what KFA. So you should mention it in your general examination presentation. Okay. Okay. So any other questions or doubts anybody has? So we have still not answered the imagining Sheila's doubt that he has got spasticity and the power is still full. Okay, we will think about it. Yeah, that's why the only thing I can explain is that UMN lesions, the power might not be fully lost. You'll have some power compared to LMN where the power will be very, it will be like less than 2 or 1 by 5. That's all right. But it is, who else saw the patient? No. What is the tone is spastic? Huh?
I some only one side, but it was slightly rigid.
Rigid, okay. So the rigidity will fit into his disease because
but the reflexes are this.
So more pyramidal involvement rather extra pyramidal is only very slight. It's a broken saccade.
History of tremors, some
tremors. So the tremors are there. The saccades are lost.
I thought we had rigidity, so that at least activated rigidity. I have activated.
But it's tonus hypotonus.
If you're not able to elicit tone, you're stuck. You don't know whether this is true hypotonia or not. What will you do? What is called the Frommenstein? If you are something, no, but something you're there. Tell us the limb only. You actually have to squeeze the hand. So if you're checking tone on the left side, please ask them to squeeze and open the hand on the other side. So you will be able to elicit the tone better. If you're actually thinking they're resisting or not, you're not able to correctly identify the tone. So this is there because It's not something, so please read at least tone and because of today. Okay. So if you have, if you're confused on whether it's fast, if it is fog, wheel, what it is, so you can do this and correctly assess and identify the tone. Anything else you have? Any other questions for Brightlin or me? Oh, we have. Okay. So Brightlin, can you tell the differentials for each of the cranial nerve involvement and ataxia? Anybody can help, Brightlin? Narendra? The cranial involved are 8, 9, 10. So there are some differentials for that. 8, 9, 10 will be involved with CP angle humor that we can get away with. Then anything else? CV junction anomalies. So that is what the question is all about. So if you say 9, 10 and ataxia, what are the CV junction anomalies you know?
Arnold Chiari.
Arnold Chiari, then
Dandy.
platyphasia, then invagination of the base skull. So all that will cause 9, 10 and cerebellar ataxia. So CV junction anomalies. So that brings us to an important point, which actually Brightlin didn't tell us, which was height neck ratio, neck movements, all that has to be measured in your CNS case. Okay, always mention height neck ratios. Okay, so any other questions? If there are no further questions, we'll close this meeting. And thanks, Brightlin, for presenting. We give her an applause. And because she's the only presenter, I have been told that I have to give her the prize. So thank you very much.